because at this point, this should be absolutely review for you guys. Glenohumeral joint. What is that, Jess?
Connection between the humerus and spinal.
Yep. Exactly. That's exactly what it is. What kind of movements can we do at the shoulder? Dani?
Flexion, extension, abduction, circumduction, and like horizontal abduction, abduction.
Yep. And rotation.
Rotation. Yeah, of course.
Those things. Yep, all of those things. Important landmarks. Superior angle, inferior angle, medial border, lateral border, glenoid fossa, coracoid process, acromion. What attaches to the acromion, Trev?
The long-headed biceps and the
No. Acromion. Anyone want to jump in? An acromion muscular origin or insertion, and there's both. Two muscles that connect either side of the ridge of the spine, the acromion and the lateral third of the clavicle.
Deltoid.
Yep, that's one. Middle head originates from the acromion. What's the other one? We talked about this orientation of two muscles that connect, one from the underneath, the other from over the top, on those three attachment sites.
upper trap.
Yeah, well, trap. Yep. Upper trap goes to lateral 1/3 of the clavicle. Mid trap goes to acromion. Lower trap goes to spinal scap. That follows the same organization as the delts. Anterior head to the clavicle, middle head to the acromion, posterior head to the spine. Cool. Sarah, what are the three muscles that attach to the coracoid process? And I won't.
Bicep brachia,
Yeah, which head?
long head,
The other one.
short head.
Yep. Two more.
Pec,
Yes.
main,
Yeah, no.
minor.
Other one. Yep, that one. And one more, and it's got coracoid in its name, sort of. It's a shitty muscle. No one really cares about this muscle. Coracobrachialis.
Yeah.
That one. Kind of a mixture of an adductor and a flexor of the humerus, because it goes from the coracoid process to the mid-medial third of the shaft of the humerus. Yeah, cool. Any muscles that attach to the superior border?
Levator scap.
Yeah.
Levator scap. Yep. And what does it do?
Levator scap.
Causes neck pain.
Isn't that nice? Isn't that nice that it does what its name is? And yeah, it does. It's also a pretty strong mechanism of neck pain as well in a lot of folk. I haven't listed them off here. I should do that. But muscles that attach either side of the glenoid fossa, one on the infraglenoid tubercle, the other one on the supraglenoid tubercle. Do we know what those are?
Tricep, right?
Yeah, but
Tricep.
which way around?
Infra is tricep.
Yeah. And
Supra.
long head of the bicep goes from the supraglenoid tubercle. That's these little humps, just here on the underside. You actually can't see it in either image, but on the underside and on the top end of the glenoid fossa there. Cool. What inserts in the bicipital groove? Yep, what else? Always, when you think lats, think teres major. The lat's little helper does all the same things, as it shares all the same functions, and inserts in the same spot. It doesn't come from the same place, but it inserts in the same place and it shares all the same functions. So teres major, lats, both insert into the intertubercular groove or the bicipital groove or sulcus, which is this thing here, right? It's called that because it's the valley formed between the lesser tubercle and the greater tubercle, right? And that's where the lats and the teres major insert. Anything else?
Serratus?
Pec major. Serratus. What does serratus do? Protracts
Yeah.
and upwardly rotates
Yeah,
the scap.
rotation.
Comes from the rib cage, goes to the medial border of the scap. Good guess though. I'd rather you guess than not say anything at all. What's this? Deltoid tuberosity. What inserts there? Sure does. What inserts on your lesser tubercle?
Some stuff.
Only thing, right? Only thing that attaches on that little bony landmark. What attaches on your greater tubercle, Jess?
Supraspinatus.
Yep. And?
Infraspinatus.
Yes, and?
Teres
Yeah. Yeah, 3 of your 4 rotator cuff muscles attached there. 2 of them work to externally rotate your humerus. The other one works to initiate abduction, abduction of the humerus. Anyone list off which function goes with which muscles?
Supraspinatus does initiation of abduction. The other two do external rotation.
That's right, teres minor and infraspinatus. And that makes sense because if you think about having a glenoid fossa here, and then the supraspinous fossa sitting in the scapula there, and the tendon going to here, you can imagine that would initiate abduction, right? Just by its line of pull, pulling across the top of the humeral head. Then you've got 2 muscles coming from back into the wall, and their tendons insert right there on the greater tubercle. You can imagine that they're going to pull back into the wall and cause that humerus to externally rotate. Right? This is why it always pays to know your origin insertions as well as your bony landmarks, and you can deduce functions based on those things as long as you're super sure of it. Yep, cool. Lats, where do they originate, Trev?
Posterior iliac crest, thoracolumbar fascia.
Some spines as well.
Transverse processes of
No,
T7,
spines.
T12.
Spinous processes.
Spinous processes.
Yeah.
T7, T12.
Yep.
And
T7 through T12.
yep.
Ribs.
Associated with those spines.
8 to 12, isn't
7 to 12, yep. Could be 8 to 12 actually. These are somewhat arbitrary, right? It kind of depends. There is some room for variation depending on the person. Yes, it's somewhere in there. You could say lower ribs and I'd still probably take that.
For some poor people, inferior angle of the scalp.
Yes, yeah. Really important to keep that in mind. That in some people, there will be actually a fibrous connection right there. And in others, in a slight majority of people, you'll be able to just slide your hand down there and there won't be a fibrous connection to the inferior angle.
Is there an easy way without being a genius to test that?
No.
No.
Nah, you're just going to make educated guesses based on whether they have super tight traps and lats, and they also have super junky shoulders.
So they'd go into like heavy depression or something like
Yeah,
that?
they'd have a really hard time upwardly rotating their scap, and it would be associated with the fact that you could roll the tendon of their lat, and you'd find that super gnarly in that person. And then you'd be able
You
to make
can
an educated guess.
You can kind of feel it, like if you're palpating, because I've seen it on clients massaging there's like a distinctive kind of like adhesion
Mm.
right on the bottom.
Yeah.
You can kind of but you've got to actually palpate that.
Yeah, and some people
Yeah,
you can.
pretty much.
And some
And it
people
could
you
be
can.
it could be like a more of a fascial thing than an actual. Yeah.
Yeah, we're talking about a fascial thing.
Yeah.
Absolutely. If it's dysfunctional, then you might have scar tissue built up around it. In some people, it'll be more distinct than others. And only if you can palpate someone and tell something from that. Most of us are just PTs, right? That's not something that we do. So no, in the realm of PT, no, there's not a way that you can easily tell that. Teres major, that's little helper, right? Does all the same stuff, goes to the same place, just comes from the inferior angle of the scap. Pec major has two different heads, right? One does flexion, the other one does extension, right? Upper fibers do flexion, lower fibers do extension. Working together, they do horizontal adduction. They do some other stuff as well. Run deep to the biceps, down to that greater cervical and bicipital groove. Delts talked about. Brachiobrachialis we talked about. Sarah, remember that one? 3 muscles attached to the coracoid process. Rotator cuff. I think you guys all know these now, yeah? Yes? Yep. You're good with those. Danny, I know you're good. Trev, got your rotator cuff pretty sorted. Not personally, but you know the... Cool.
Yeah, the shoulder's a particular area of interest to me.
Yeah. That's the nice thing about getting older and having some dings, right? Is I'm the same way with thoracic extension and respiratory problems because I've had problems with both. Scapulothoracic joint. Is it a synovial joint? No, it's not, is it? No. It's kind of a pseudo articulation between the serratus anterior on the rib cage and the subscapularis on the anterior face of the scapula. Kind of glides around on your rib cage. Pretty cool little thing. There goes some force vectors. There goes some winging. When we talked about this probably being an example of nerve damage, the long thoracic nerve. We talked about this being something that's present in the vast majority of females and a decent amount of guys as well. Is this slightly less exaggerated version of winging. Serratus anterior, ribs 1 or 2 through 9, medial border of the scap from the bottom, right? That picture's a cool one to really kind of illustrate that. You can only see part of it there, but check your notes. There's protraction, upward rotation. I think of all functions we've looked at so far, scapular functions are the toughest, just because we're not talking about a lever system anymore in the sort of conventional sense of the word, right? We don't have a hinge or a ball and socket that behaves like a lever. We have a floating bone on a plane that kind of shifts around very dynamically. Like we talk about it moving like this, it doesn't really do that. It does more sort of this sort of stuff. It tends to do everything at once. And so it really pays to know your movements of the scapula in order to be able to figure out what's actually going on with the scapula as it gets acted on by specific muscles. So what does the rhomboids do on the scap?
Downward rotation.
Huh?
Downward rotation.
Yep.
Retraction.
And retraction, yeah. Right, makes sense because it's pulling that way. So it pulls the scapula around and down, and also in. Yep. And we're not making distinctions between minor and major because I think it's a stupid distinction. Traps suck in terms of learning origin, insertion, and function. Spans from the external occipital protuberance, the nuchal ligament, which sits flush and on top of, or superficial to the spines of the cervical vertebrae, right? So that's the nuchal ligament. You can actually see it in some people if you put them into a hard chin lock. You can actually see a little ridge. That's not the spines, that's the nuchal ligament. Spans T1 through 12 as well. And your distinctions kind of run here and here. So we say that's upper traps, which I think we say is like, includes, how does it go? Goes nuchal ligament is upper, then middle is T1 through 4 or 5 or something?
Five, I think.
5. And then the lower is everything below that. As we spoke about, it goes to the lateral third of the clavicle, the acromion, and the spine of the scap, in that order from upper to lower. And then the actions I've simplified quite a lot for you guys. So you can pretty much think of the middle fibers creating a retraction action at the scap, the lower fibers doing depression, and the upper fibers doing elevation. And then the upper and lower pull from different directions to create the same action. And what's that called, Darnie?
I didn't catch that. It's daydreaming.
Yeah. You're thinking about traps though, right?
Yeah.
Yeah, you're totally thinking about
Yeah,
traps.
that's what I was thinking.
Upper and lower traps act on the scapula from different locations to create one movement. And what do we call that?
Stabilizer.
Nah. What do you call that, Jess? Sarah?
I'm gonna say upward rotation.
Yeah, it is upward rotation, but I'm asking for what that's called when we have that relationship between two muscles that act on a joint from different locations to create a single movement.
Oh, force couple.
Yes, thank you.
Sorry,
Force
yeah.
couple. It's a force couple. Right, because the upper pull from there, and they pull from there. One pulls up, the other pulls down, but together they create upward rotation.
Yeah, well, you asked me that question.
Yeah. Levator scap we talked about. What's the origin of the stupid levator scap? Stupid injury prone levator scap. Why does the levator scap get injured? Fred? You're the one that said it. Our little friend's synergistic dominance is why it gets injured. Because the traps stop doing their helper job, or their prime mover job. And this helper job becomes a prime mover job. And so the levator scap is prone to insidious strains. Insidious is a fancy word for something that creeps in, and it's generally what we use to speak about chronic injuries, things that happen without a specific event being associated with them. Right, so that's something that can be fairly common with levator scap, and if you get into someone's superior angle of their scap, for a lot of people, that's going to be relatively sore.
Great trick point.
Yeah, really good trigger point. Coracoid process, superior angle of the trap, of the scap, and the tendon of the lat are my favorite triad of trigger point areas for the shoulder. Pec minor, speaking of trigger pointing, some of the upper ribs, 2 through 5 or something, up to the coracoid process. When the scapula is fixed, this has serious implications for respiration. Otherwise, it does some strange, hard to picture movements of the scapula, right? The rib cage is fixed, and the scapula is moving. This does what? Protraction, depression, and downward rotation. And if you think about it really hard, you can figure out how that would look. Yep. That's them, the elbow. We talked about this a fair bit, right? Because there's a few sort of unique landmarks here with funny names. We've got something called your capitulum, we've got something called your olecranon and your coronoid process. We've got associated coronoid and olecranon fossae on the humerus. What else we got going on? There's a bunch of stuff going on here, right? Because we've got two different joints. We've got a radio-ulnar joint, and we've got the elbow joint proper. Remember that radio-ulnar joint is what allows us to supinate and pronate with reckless abandon. This is just quite I think, a good image to demonstrate that relationship between the head of the radius and the radial notch of the ulna, and the role that the annular ligament plays in keeping that head of the radius flush on the ulna. Oh yeah, I included that. We talked about that. It's one of the places that the biceps insert. It's right there, so you can see how they could act to pull up on the radius and take you into supination while they're also working to flex your elbow. Just make sure you touch on that, up on that in your own time. These kind of novel bony landmarks at the distal end of the humerus, how they apply to the elbow joint. Radial sulcus, I've called out here in particular because it's a nice landmark for you to differentiate between lateral and medial heads of your tricep. It's what it's kind of the easiest landmark to make that differentiation. They both come from the posterior surface of the humerus. Lateral head comes from above the radial sulcus, and the medial head comes from below it. Yeah, so many images of the radius and ulna. That's a good one to show you that sort of crescent shape of the ulna. Why we call these two different things, because they work as two quite separate bony protuberances, and also what necessitates those two deep cavities at the distal end of the humerus, right? That coronoid fossa and the olecranon fossa. Moving on, biceps. You guys know that. Brachialis. Sits deep to the biceps, comes from the anterior shaft of the humerus, goes to the coronoid process and the ulnar tuberosity. Helps the biceps. Or maybe you could even say that the biceps helps it in flexion of the elbow.
Is it coronoid process or coracoid?
Yeah, well that's what's confusing, right? Particularly because they got it wrong in that diagram.
Same thing, so less and different.
It's not. Coracoid is this guy. Coronoid is this guy. Yeah. And this diagram spelt it wrong. They called, what was it? They called this one the coracoid, didn't they?
Oh, right. This is called a coracoid. It's a coracoid.
No. In the diagram they called this the coracoid, and I've crossed it out and put coronoid. What, that's right?
No. As in, you're talking about
Where
that
is it?
scapular diagram, right?
Oh, was it? I was on the scapular diagram. Oh, okay, sorry. I thought it was on one of these.
No.
Oh, so they had that as the coronoid, and I've crossed it out and put coracoid.
Yeah.
Anyway. Yeah, so this is the coronoid process, not to be confused with the coracoid process. And then there's the, what's it called? It's another similar derivative of the same word. The, it's another C and C. You don't need to know it, so I won't even bother trying to remember that one. Brachioradialis, kind of a combination of elbow flexor and something that acts on your proximal and distal radial ulnar joints. What's really interesting about the brachioradialis, if you're dealing with nerve damage, is that it's innervated by the radial nerve. It's the only elbow flexor that's innervated by the radial nerve. So if you have someone who has plesia of their musculocutaneous nerve, which innervates the rest of the elbow flexors, you might find that someone's developed the ability to still get some slight flexion out of their elbow through hypertrophy of their brachioradialis, because it's innervated by a novel nerve, the radial nerve. Just a little sidebar, kind of interesting when I found that out. There they all are. Right, so your biceps and your brachialis, both innervated by the musculocutaneous nerve. And then you've got another flexor of the elbow here, the brachioradialis. But that is innervated by a nerve that runs up the back of your arm called the radial nerve. And so if someone has nerve damage to the musculocutaneous, they may still retain some ability to flex their elbow based on the brachioradialis. Triceps, all that good stuff, the wrist. Ay, ay, ay. Film we might have to wait, guys, because we've got to finish up the wrist and get through the spine. Yeah.
Damn. Terrible.
Yeah.
Me and Jess are devastated, aren't we, Jess?
Yeah. It's the lesser of two evils, though, really, isn't it? 'Cause it's like, do you really want to stay in an anatomy lecture
Yes.
or do some videoing? Well, I know, Trev, I know you love this as much as I do.
You can have your videoing.
So the wrist is kind of the articulation between the radius and the scaphoid and the lunate, which are two of the carpal bones of the hand, of which there are many, 8 in total. So you've got that articulation, then you've got a bunch of these little pebbles, carpal bones, and you've got metacarpals, and then you've got phalanges on the end there. And that kind of makes up your bony anatomy of your hand. What's interesting about the radius and ulna here, and I'm still a little bit embarrassed by how long I went through my career before I realized this little relationship. The main articulation at the elbow is the ulna, right? And the radius sits off to the side. But then that flip-flops here. So the ulna goes from being thick and prominent at the elbow, becomes the little accessory at this end. The radius starts as being thin and accessory at the top, and it becomes prominent articulating point at the wrist.
So what the radius breaks, it comes the brunt of the forward force.
Yeah, sure, absolutely, yeah.
What was
Yes.
that? I didn't hear that, so.
What Dani just said?
Yeah.
Just that radial fractures are more common than ulnar fractures on an outstretched hand, because the radius takes the brunt of the
Yeah.
force from the ground with impact.
Scaphoid is the other one, isn't it?
Yeah, scaphoid fractures are horrendous. Yeah, because really poor blood supply, and they do not.
I've had 2.
Yeah, nice. Yeah, so you'll be able to speak to that, but they can be really, really problematic in terms of bone recovery. Yeah. Anyway, so that's your relationship there. And like I said, I don't know. I probably learned that 6 or 7 years ago. Took me way too long. These are the movements that happen here: flexion, extension, radial deviation, and ulnar deviation. They're novel movements of the wrist that we don't see anywhere else. Looks like that. Right, so ulnar deviation, radial deviation. Ulnar towards the ulna, radial towards the radius. Cool, everything else is pretty straightforward. Flexion, extension, circumduction. You can't rotate your wrist. Rotation at the wrist happens at the distal radio-ulnar joint, right there. And I'll say this again, like I encouraged you last time, to watch a video that shows the way the radius and the ulna move around each other when you pronate and supinate. If you just Google that and look at a video, it's kind of helps bring it all together. Remember that these little schematics on the side are showing kind of a mechanical version of what that joint looks like. Well, I don't fully get this one. Usually they're pretty good. Oh, that's busy, isn't it? That is busy. That is a busy slide. Anyway, make of it what you will. This isn't super important. There goes a little PG mnemonic for the carpal bones. They got me through anatomy school. You don't need to know this for the exam. So just know this general concept, don't get caught up in the details. Ligaments of the hand and wrist. Oh, there's a lot. This is kind of interesting, this extensor and flexor retinaculum. We talked about that a little bit. It's this thin sheath of fibrous tissue that's only job is to hold the tendons of your arm down when you contract them, otherwise they would tension like guitar strings and pop away from the joint, which would have negative implications for their leverage ability. A whole bunch of bad stuff would happen. So your body's evolved to have this thin fibrous sheath that's just there to hold your tendons down. Every time I learned something like this, I just thought, wow, man, evolution, huh? That thing is crazy.
What's it called? What's the shape called?
A retinaculum. And there's a whole bunch of them at most hinges, really. You have retinaculums at the feet, at the wrist. No. Also, although the bicipital aponeurosis acts a little bit like a retinaculum. Yeah, kind of a cool little thing. There goes Gray's image. Can you imagine dissecting this out and drawing this picture and naming, you'd be looking down here, it's like, is that the same ligament or is that a different one? Yeah, you don't need to know any of that stuff. I don't know this stuff. This is OT's, occupational therapist business. Even most physios don't necessarily know this stuff well.
Having that many tests is a killer.
Yeah.
Let's do that.
Yeah. I was tested on this, but I no longer know it. Yeah. Nerve innervations. Okay, let's talk about carpal tunnel syndrome. So I really like this image because it shows the relationship of the median nerve being trapped between that carpal ligament and the carpal bones, including all the tendons that travel within that space as well, and how that can get aggravated, and then its terminal branches that supply that part of the hand. Pretty common these days. A lot of office workers present with this because they don't lift heavy stuff, they don't have strong wrists, and they do a bunch of moving their digits in a flexed hand position. Moving your digits isn't too bad if you're doing it with a neutral wrist, but when you do it like this, or even like this, that becomes problematic. And why is that? Yeah, sort of. Yeah, but why does it create pressure?
Traps in it.
Yes, it impinges the nerve.
Yes. Jess.
That's us.
Active and passive insufficiency, right? That's why it's creating extra pressure. That's why the nerve gets impinged. Active and passive insufficiency relationships at the wrist. Yeah, because if you flex or extend the wrist and then you move your digits, You're talking about muscles that cross multiple joints. That stuff takes place, right? Hint there being that all of these tendons of these muscles travel along that same parallel line of the median nerve. Man, that's a horrible slide, huh? You'd think that I'd look at that slide and I'd go, let me split that across a couple different slides. Yeah, I guess I wanted to make it a summary slide, and it's just so much information. This is important. Know that almost all of the flexes of your digits and your wrist originate on your medial epicondyle, right here, and the extensors come from out here, or around that area, or in the lateral epicondyle. Tennis elbow, the backhand elbow is lateral epicondylitis. Golfer's elbow is medial epicondylitis. It's aggravation of the muscles that originate from those points. Okay, so all of your anterior compartment, all of your flexors are in the anterior compartment, and they come from the medial epicondyle.
Why do some people get tennis elbow and some don't? I played for like 12 years and never
Yeah, lucky you. Single-handed or double-handed?
double-handed backhand.
That's part of it. And then some more of it will come down to individual anthropometry. And then more will come down to mechanics of your swing. Yeah. And then why do just as many tennis players develop golfer's elbow as they do tennis elbow? Is another great question. That comes more from serving action. Yeah. Yeah. And then the posterior compartment, simple. All comes from that lateral epicondyle. Right, so all of your extensors, all of these guys, and all the guys that do that, almost all of them come from that lateral epicondyle. Done. Don't quote me on that,
Thought
but
you were gonna drop the mic.
nah, because we're not actually done, right? We're just done with that series. We're not even going to mess around. We're just going to go bang. Whew. Okay.
I need to use the
Yeah,
bathroom.
go
Yeah,
ahead.
so do I,
This is good.
actually.
This is good intermission, and it's also a good time for me to tell Matt.
How you going with all that trip?
It's not fun. Not fun. It's fun, just not good for my old brain that doesn't absorb like it used to.
It's good to know. You can apply it.
Oh, I love it. I love this stuff. It's just
Yeah, just try to apply it to stuff and then you'll learn it better. You'll associate it with something.
You two are absolutely smashing. I'd like to challenge you more, but there has to be a midline, right? At least this way, hopefully, Dani, I hope you're relearning some of your anatomy.
No, it's really good because I forgot a lot of it.
You forget it, right?
Yeah.
You
so
treat
much to
anatomy.
fucking learn.
You treat anatomy like all your other subjects, and
Learn
you
it,
learn
forget
it for the class, and you forget it. And if there's one realm where you shouldn't do that,
It's probably
it's anatomy,
anatomy,
because you can use it
Throughout.
forever, right?
Yeah.
Like throughout your job, particularly pertinent for you as you go into physio. Like, you know, for me, for example, I have to review for sort of 20 minutes
And it'll come back
each
to
of
you.
these lecture
Yeah.
slides, or slide decks,
Yeah.
and then relatively fluent again.
Yeah, because like I find that some of them I just remember just because they're more like
Yeah.
obvious.
Yeah,
But then
yeah.
like you little like the deep sits and stuff, and then they get a bit
Yeah.
more difficult because they're not as
Yeah.
prominently.
Or some of the broad attachments
Yeah.
that you remember some of them, you forget some of
Because
them.
they got like board attachments. It's not like it isn't necessarily know where they are, but at the same time it's lesser to a
No.
lesser degree.
Totally,
Because it's like
totally. You need to know sort of general
Area,
conceptual
yeah.
of where that is. Yeah.
doesn't really matter. It's more like the ones that have that one attachment point that become a bit more important. Like Pecmina being a really
Yeah.
good example. Of
Yeah,
that.
for sure. Yeah.
Because
Coming
that's
from the
obviously-
chiropractic process,
Yeah.
you need to be able to
Go
work
find
that
it.
area.
Yeah,
Yeah.
go find it.
Mm.
So yeah, it's stuff like that. But it's really good because, yeah, like I said, I've got a lot of it.
Mm.
It's just kind of good to get back into it.
Get it back
And
in, yeah.
because I think next SEM or next year at some point, I'll
Yeah.
probably end up doing advanced anatomy.
Yeah.
So this will be good because I'll be a bit of a refresher before I go straight back into that.
So good for that because that's where you start looking at
The stuff that
hypotheses specific relationships, right? Like where on landmarks things are originating and inserting. That's a depth that
we did some of that. Like, what it's Terry's majors in between lat and lat Dorsey's in
Cold
between
in
Terry's
here.
major
Yeah.
and Peck major, wasn't it? The lady
Yeah.
between
Say-
two
say it
majors.
again?
It's blown out.
lat. No, Terry's major
Mhm.
is between. Yes, it is. Yeah, yeah.
Because
Is
it's
that
like I remember that little you know it was like the lady between two majors. That's how you remember
Right.
lat Dorsey's in
Yeah.
between the two of them.
It's nice when you've got little
Things like
memory
that, yeah.
tools like that. Okay, guys, spine and nervous system. I won't have time to cover all of this in the detail I'd like, so we're going to try to get through all of it. Make sure you revisit the things that are a little bit unclear. In some ways, this should really precede Anatomies Part 1 and 2, because so much of the nervous system tie-ins rely on you having an understanding of the bony anatomy, as well as the orientation of the spinal cord, as assumed knowledge for these. But anyway, here we are. Bony anatomy of the spine. We know we have 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacral vertebrae that are fused into one, and then 4 fused vertebrae that make up your coccyx. A little point right down at the bottom. Now, your spinal cord spans this, right? Cerebrum, brainstem, brainstem, and then spinal cord running the breadth of the true vertebrae. And each vertebra has some unique things that go along with it. For example, your cervical vertebrae have a transverse foramen, which is where your, well, what travels through there, Danny? Just all of your cervical nerves, all 12 cervical nerves. Well, actually not all of them. Some of them travel down through that space. Like the accessory nerve, which innervates the traps. All of them have a vertebral foramen, right? So that's where your spinal cord travels. The cervical vertebrae have a bifid spinous process, which is to say a forked spinous process, whereas the thoracic and lumbar don't. The lumbar are the biggest, then thoracic, then cervical are the smallest, and of course C1 and 2 are really unique as well. You don't need to know any of this, by the way. I'm just saying that there's some interesting differences between different vertebrae, and in school you'll be given models of different vertebral bodies and have to be able to identify which is which. Of course, the thoracic, another giveaway for thoracic vertebrae is they have a costal facet, which is where your ribs attach on each vertebrae at the back. Now the atlas and the axes. So this is C1 and C2, right? And what's interesting about C1 is that it has, well, for one thing, it has no body on it. And it's got this interesting little ligament, a little bit like your annular ligament at the elbow, that allows the dens, which is this sort of spike on the axes that allows your atlas to rotate really well. the dens is also called the odontoid process. Okay, so that's your atlas and axis. I think I might want you to know what the dens is. And so this slide, just make sure you read over that slide. Spinal cord, we've talked about this, and there's just one or two questions on it in the exam. Talking about the front or the ventral side of your spine being associated with motor cues, right, so output, and the dorsal being associated with sensory input. And then the roots of the nerves that spread out from your spine having that same association for as they leave the spine, they become mixed spinal nerves, which all those nerves that we know, like the femoral nerve and the obturator nerve, various terminal branches, the brachial plexus, things like that. Okay, so that's it for that slide. If that, just some very general conceptual stuff around how the spinal cord is arranged. We're talking about the trunk now, right? Trunk anatomy, trunk muscular anatomy. Before we get into that, even more superficial than the musculature of the trunk, you have these two broad fibrous sheets, one on the front and one on the back. The front being the abdominal ponderosus. It's a major attachment site for all the muscles of your anterior trunk, rectus abdominis, internal and external oblique, TRA, transverse abdominis, and then of course we've talked at length about this thoracolumbar fascia, which sort of forms the base of the lats, right? You see it's continuous with the lats, as well as a whole bunch of other stuff. Thoracolumbar fascia being an important part of our POS as well, right?
Kate, I'll come out there, sorry.
Yeah, we've talked about this implicitly when we talked about our sling systems, didn't we? Of course, you can see how the abdominal aponeurosis is central to your AOS, thoracolumbar fascia, to POS. These are tissues that are designed to gather passive tension and then spring back and create or assist in rotational and flexion extension motions through the trunk. So really, really important for all sort of sporting activities. This is kind of where guys like, what's his name? He's a bit of a nutcase, bit of a cult leader.
What
Functional
field?
patterns.
Portolato.
Oh, Jesus. Aguilera.
Yeah,
Everything.
Christina.
Crystal bag, yeah.
Yeah. Yeah, but he spends a lot of time on AOS and POS to ad nauseum. But that's his deal. Okay, muscles of the abdomen. External oblique. There it is. See that it's kind of. I'm trying to think of how I test you on these because trunk musculature is probably the toughest in terms of origin and insertion. Try to have a general picture of where it goes, right? I think, what do we do? Danny, external oblique is front pockets or something, and do you guys do that? No, okay, forget it. Rib cage, anterior third of the iliac crest, inguinal ligament, some of these sort of things. You can see that this kind of infests in between the feathery bellies of the serratus anterior on the rib cage. And what you must remember is that the external oblique rotates to the contralateral side and that the internal oblique goes to the ipsilateral side. Remember, contralateral means the opposite side. So that this external oblique will rotate me to the left. My right external oblique rotates me to the left side, and vice versa. And this, again, relies on fixed points, right? So if you're hanging from something, these flip-flop. which makes it extra confusing. But anyway, for conventional discussions, external oblique is a contralateral rotator of the trunk.
Sorry, what did you say if you were hanging?
Then your fixed end becomes that, and so you're pulling from here, and you become an ipsilateral rotator.
Okay.
External obliques become an ipsilateral rotator. Just that we have conventional origins and insertions, but an origin is only sort of a predetermined fixed point. If you fix one end and you allow the other end to move, then your origin insertion flip. Does that make sense? Essentially, if the origin is the lateral border of the ribs, so we're saying if the rib cage is fixed in place, or the upper trunk is fixed in place, then the pelvis is our moving end.
It's like open and closed.
Yeah.
Yeah, essentially, yeah. It's tying with open and closed chain. Yeah, sure. Not sure why I'm struggling to describe that so much, but yeah, I think you get the picture. Rectus abdominis, good old six pack. It's actually deep to the abdominal aponeurosis, right? It's pretty much a thin sheath of white.
Shin feet.
A shin feet. That sits over top of it, right? And the rectus abdominis is a pretty weak muscle. Pretty weak muscle, plays second fiddle to the obliques, even in flexion. Everyone thinks of this as being the sort of prime mover in flexion of the trunk. If you saw this muscle, it's about that thin. It's hopeless. Really relies on early reflexive contraction to be able to do its job well. And its main job, as we talked about when we were talking about basics of barbell training, is as a anti-extender, right, as opposed to an active flexor. The main reason that this muscle exists is to stop you from going into injurious states of extension. And it makes sense because it's just not that strong. It's not that good of a trunk flexor. Most of the time we're doing flexion actions, we rely more on the obliques working together and the hip flexors. But anyway, I digress. Kind of runs just from the bottom of your sternum, or the xiphoid process, which is the bottom of the sternum.
Should the insertion be xiphoid? I mean, origin be xiphoid, rather.
No, because it's a trunk flexor. So they're saying that this is fixed, and this moves
Down.
Yeah. Although the distinction between origin insertion and the trunk becomes super murky, because most of the time with levers you have most of the time one end is fixed, and so it's easy to think of origin insertion. Less so with muscles of the trunk. This exact same question came up with Matt and Giannis when they were going through this. They had some of those same questions because it felt like it flip-flopped. Anyway, six pack does flexion, sort of more like anti-extension. Also, if you contract one side, you'd get some lateral flexion of your spine, right? And then also maybe some really weak rotation. I should probably take that out because I think that's pretty minuscule. Internal oblique. You can see these fibers run in the opposite direction. So your external oblique was like this, right? Came from the rib cage down, like this. Whereas the internal oblique run the opposite direction. So they crisscross over each other, and that's why they have separate functions when it comes to rotation. Contralateral for the external oblique, ipsilateral for the internal oblique. But otherwise, a lot of the same things, right? You can see how this has a strong connection with the abdominal aponeurosis, iliac crest, Even has some connections back here through the inner side of the lumbar fascia. I don't think it's designated here. Oh, it is, sorry, thoracolumbar fascia. Those bits. You can see this kind of strange loopy bit of the inguinal ligament. There's a space in the internal oblique for the inguinal ligament. We won't get into that too much. Yeah, you can see rotation when it works unilaterally. It has an ipsilateral rotation effect on the trunk. When they work together, they're a strong flexor of the trunk. Transverse abdominis, or a lot of people refer to it as the TRA. It's the thinnest, deepest muscle. If you cut through this, you go straight into the abdominal cavity, which I learned firsthand, unfortunately. But essentially, think of this as like a corset. Its fibers run, believe it or not, transverse across the trunk. And so the origin, if you think about it, it's inside the underside of the rib cage. Has a very close attachment site with the diaphragm. Comes up under the rib cage, inner lip of the iliac crest, and then the thoracolumbar fascia. Right, so it's coming under the ribs from that fascial connection, and then from the inside of the iliac crest, and then it comes across to the middle, the abdominal aponeurosis, the linea alba, which is that line in your abdominal aponeurosis that gives the abs that certain look. Doesn't really do anything much in terms of movement. What it does is it creates pressure in your abdominal cavity. So it compresses the ribs and the viscera being your organs, your abdominal organs, and increases intra-abdominal pressure. And like we spoke about when we talked about the holding your breath bit, the Valsalva maneuver. All of that stuff, all of that increased intra-abdominal pressure stabilizes your spine against compressive loads. Speaking of, got the diaphragm. You see it kind of sits like this inverted bucket up in your rib cage. You can imagine how that has tie-ins with your TRA. And then it has these projections down onto the bodies of your lumbar spine. And that's what it looks like if you're looking up into somebody's, we would be inside the abdominal cavity, looking up at the diaphragm, which is acting as a wall to the thoracic cavity on the other side, right? You can see the esophagus. I can't actually read which one is which. Yeah. You don't need to know any of this stuff. What's more important for the diaphragm is that you know the function really well. So it increases thoracic cavity volume to assist in inhalation, and it helps increase abdominal cavity pressure to assist in stabilizing the trunk. Yeah? That's the diaphragm, the back. Erectus spinae. Okay. You got 3 different ones, right? What mnemonic do you guys use, Danny?
Yeah, I don't just remember it.
I love spaghetti was the one they taught us. I love spaghetti. I just remember them too. It's only 3 muscles, right? Like, get over it. Iliocostalis, longissimus, and spinalis. Iliocostalis, you want to remember that's the outside one because it has costal in its name. And costal refers to the ribs. And you can see that it's the widest, it has connections out on the ribs. You can see they all come from a common origin, down at the sacrum and the iliac crest and the fascia and the spines and all of that stuff. God, I wish I had some water. Spinalis, as you can imagine, inserts all the way up the spines of your vertebrae. Iliocostalis, like I said, has some connections along the spine, branches out onto the rib cage, and comes back into the transverse processes of the cervical spine. I just want to explore some of the sort of concepts and orientations of these muscles as opposed to specific numbers of vertebrae that they span. So I've included all of that. You'll see on the slide there's a lot of numbers, right? Don't worry about these numbers too much. Just remember that these three muscles is the muscles we work with, things like back extensions, right? They come from the posterior iliac crest, the sacrum, and the spines and transverse processes of your lower vertebrae. And then they kind of branch on up the spine. Iliocostalis goes up to the ribs, everything else kind of stays kind of straight up the middle. Spinalis, of course, goes up the spines, and the longissimus goes up the transverse processes. So remember, your spines stick straight back out of your back, and your transverse processes are out to the side. That's, to me, the important takeaway of this slide. Of course, they extend your trunk, they laterally flex your trunk, and they rotate your trunk. If they're working ipsilaterally, right? Like if you're only contracting the muscles of the right side of your erector spina, they're going to rotate and laterally flex to that same side. Good old QL. Everyone likes a good fiddle of the QL. Iliac crest up to the ribs. Mainly does lateral flexion concentrically, although it's more of, again, it's more a muscle that holds up your ilium, kind of assists the lateral stabilizers of the hip in minimizing hip drop. Right, but it goes from the iliac crest up to that first rib, and then also attaches in towards the middle on the transverse processes of your lumbar spine. I'm going to get some water.
Is it a good extension?
Yeah, I was gonna
But-
say that.
Yep.
That's a nice one to have released.
It's great to stick your fingers in. You
Yeah.
get into a U shape, and then you're like, I love it.
It's not nice getting done, but after it you're like, oh.
I love
It's like the
releasing
skip
it on
through the-
people. It's
Yeah.
the best.
Yeah, so it does have a really weak extension function. So weak that I haven't included it. You really have to think about where that muscle is and its position on the iliac crest, the transverse processes of the lumbar vertebrae, and then the underside of the 12th rib. There's no real leverage there for it to be a powerful extender of your back. So we can just think about it as a lateral flexor or a resistor of hip drop. Right, like when we're walking, and our swing leg may be prone to dropping down low. The QL can help hold it up. Multifidus pretty much is just your whole spine. Just spans your entire spine. It's part of a group called the transversospinalis group, named as such because it originates on the transverse processes and then inserts a few vertebrae up. Oh, would that be? Oh, that'd be my computer dying. Talk amongst yourselves, guys. I'll try to find a charger.
Still got all the neck to do. How's exams go?
Monday I start. I'm just like due date though. I got done a while ago just so I don't have to stress about it today.
Mm.
Because when I saw Dave this morning,
Mm.
and like
Where was that at? Hornsby?
Nah, in Thornley, a little cafe in Thornley. Which is it's not that far from me, so how long does it take everyone to get to? 10 minutes.
It'll be like an hour.
Haven't
in
tried yet.
traffic.
Yeah. Where do you live?
Moorebank Way. So like Liverpool.
Oh shit.
Wow.
Yeah, that's a long drive.
Mm.
Especially with
It'd
traffic.
probably more worthwhile for you to get the train.
Yeah. Especially down Pennant Hills Road.
Mm.
Penhurst Road from
Well,
now.
hopefully I'm off peak, so it'll be easier. Just M7.
Hmm.
That's a toll road, isn't it? M7.
Yeah.
Oh.
I'm in a tax.
Can you?
Because I live within a certain vicinity of like the M5, I can get like a cashback thing with it. Yeah. If you live near toll roads, you should be able to get a cashback
Is that you,
for
Trevor?
most tax.
No shit. No.
Didn't know. Sorry, I did.
What's your max squat, Trevor? What was it at your heyday?
I got 190 in competition,
Beautiful, man.
and then I died on to 100, I think, or 205.
Deadlift?
Halfway up. Deadlift was 215.
What was your body weight?
I just saw
80,
Cara
82.
Webb
That's huge.
did a 130 clean and jerk.
Mm.
Oh, jerk actually. She did clean.
Some of the lumbers people lift
Whoa.
now are just
For a
Depressing.
chick, that's insane.
Mm.
She needs to represent Australia.
there's a couple of chicks in powerlifting that deadlift over 200 freaks.
Crazy, huh? Ah, okay, multifidus. See, origin, all transverse processes, and then insertion, just all the spinous processes, 4 segments above the transverse process. So think of it as this is kind of strands of muscle that run up every transverse process and then attach 4 segments up on the spinous process. And the only thing that you must know about the multifidus is that it stabilizes the spine. The multifidus and the TRA stabilize the spine. If I ask you a question to do with stabilization of the spine, and ask you for 2 muscles that are active there, you should think TRA, multifidus. These are 2 muscles that physios love to throw around because they sound very fancy and no one really knows what they do. Multifidus and TRA. Okay, neck. I'm being somewhat facetious there. Splenius. Don't think I tested you on it, so I'm just going to jump over it. Scalenes.
It's like 8 ways through neck musculature.
Yeah, I'm not going particularly deep, and I also don't think I tested you on it. These are just the ones that I think are most pertinent. Like, these are things that I deal with on a relatively regular basis. Sarah, scalenes are a muscle that you probably
Mm-hmm.
are familiar with. SCM.
That's your problem.
Bastard.
That's a problem. Yep. It's something that gets involved in synergistic dominance, likes to make up for weakness through these guys. The longus capitis and coli. So the SCM, don't worry too much about its origin and insertions. Any of this next stuff, don't worry about too much. They're more of an afterthought. But do know, well, we've talked about it, right? We've talked about SCM getting over-involved in holding your head up. That has really negative implications around your mastoid process, which has implications for your TMJ. Dentists deal with SCM problems. And the reason for that is because they take over from the deep neck flexors that are supposed to work to hold you in a nice tall position, and they can become dysfunctional. And I think, just personal opinion here, that it's the SCM getting overactive that switches these off, as opposed to the other way around. Just a little sidebar. Respiration. Yeah, I can talk about that another time if you're interested. Respiration. We talked about this a little bit already. We didn't talk about this though. Mechanisms of respiration. Boyle's law, we may have touched on really briefly, is the volume of a container is inversely related to the pressure of its contents. Know what that is? Boyle's law is to do with gas pressures and the inverse relationship of volume and pressure. So respiration is where your muscles, basically your intercostals and your diaphragm, expand, which is a decrease in pressure, right? When you expand a cavity, you decrease the pressure within that cavity. And we're set up in a very sensitively tuned way, so that brings us to an area of lower pressure than the atmosphere, which means that gases from the atmosphere rush into our thoracic cavity, into our lungs, and that's how we breathe. And then the mechanism of exhalation is mostly a passive one. The lung tissue has elastic properties, so after being expanded, it has a tendency to want to contract back down to its original size. Yeah, you can kind of just read through those bullet points, right? That's, I think, essentially what those detail. So contraction of the diaphragm, remember the diaphragm's like a dome, like an inverted bucket, and when you contract the diaphragm, it gets pulled down. It has a connection via something called the central tendon. And so shortening of the sarcomeres along the central tendon, pull that bucket down, and that increases the length of the cavity in your thoracic cavity, right? And then your intercostals pull up on your ribs, so they pull them out kind of like the handle of a bucket, and that increases the depth of your thoracic cavity. And those two mechanisms both increase the volume of your thoracic cavity, which has that, via Boyle's law, inverse relationship with the pressure of that cavity. Pressure goes down below that of atmospheric pressure, and that causes air to flow into our lungs. I just think that's really fascinating. You know, like we breathe all day just automatically. And it's amazing me to think about these two muscles that work on our thoracic cavity and this flow of air into our lungs via that mechanism. I just think that's fascinating. Yeah, talk about negative pressure gradients, all that fancy stuff, the alveolar, capillary barrier, capillary. You gotta say capillary or capillary? Capillary? Yeah, okay. Muscles of respiration. I think this diagram is really, really good. The important things to remember are the diaphragm, intercostals, and accessory muscles, not so much, but that's what all of those are. You can see the pec minor rearing its ugly head again. Scalenes, SCM, all that stuff that I included in the next stuff as extra if you really want to deepen your understanding of the muscles of respiration, but not necessary for your exam. This is where we test you on the ZOA. And we talked about this. This is PRI, Postural Restoration Institute, who are doing incredible work in the US on mechanics of breathing, how it applies to sports performance, how it applies to everyday performance. Really, really cool stuff. I'd recommend reading some of their content. Just particularly for you, if you're interested in the people who are changing the paradigm on everyone wanting to live in extension and instead encouraging people to get into more flexion, these guys really lead that campaign. Just spend a little bit of time on this, the zone of apposition. Remember what it is, right? It's that distance between the apex of your diaphragm and the underside of your lowest rib. And if you have a steeper apex, then you have more room for your thoracic cavity to be changed, the pressure in your thoracic cavity to be changed. That means you have more potential for an inrushing of gases, or oxygen, which is what we're really looking for here, and vice versa. You also have a better ability to change that when you exhale, sorry. Or just very briefly, in these last 2 minutes, this is something that does my head in, belly breathing. Everyone's about their belly breathing, and this is something perpetuated by yoga studios all over the world. I say it there best. I think belly breathing Q is at best incomplete, at worst it's just incorrect. Passive excessive distension of the abdominal cavity does not provide the opposing elastic tension. It does not provide the opposing elastic tension that's so important to maintaining the length-tension relationship with the diaphragm. So this idea that you can distend your abdominal cavity and have some sort of meaningful impact on your thoracic cavity is somewhat diluted based on the research by PRI. Just as a side note, it also has the has the tendency to promote rib flare. When you have someone distending their belly a whole bunch, usually the bottom of their rib cage will tend to jump up, and we know that that's not a good thing. So instead, what we focus on is 360 degrees of breathing, and you just have them think of their pillar as a balloon. The idea is to expand the entire thing. So we're thinking rib cage flaring out to the sides, up, back, everything. Just think about from here to here, expanding through 360 degrees. Just a little side note, but an incredibly critical one when it comes to cueing across our 90-90 breathing, our crocodile breathing, those few little exercises that we use as part of particularly stage 1 when we're working on breathing mechanics and correct control of epidemic, which is rib flare.
Like, people who teach yoga know that. Like, when they say breathe through their belly, are they just describing it wrong? Do they just want
Yeah, I think so. Oh, and do they know this? No, I don't think so.
Yeah.
I don't think they do. If they did, I'd like to think that they'd see the error in their ways and they'd change it.
Yeah.
That's what you'd like to think. We're getting kicked out, yeah.
A lot of them don't know about a lot of them teach when you squat, you bring your knees back and not over your toes as well.
Yeah, and that's not just yoga, right? Like that's
Fitness in
absolutely
general.
everywhere, yeah.
Part of
Pet
it just
hate.
died.
Yeah.
What, the toes of the